Welcome, everyone. I'm Mike Silverman from Western University, and I'm here with Dr. Lena Sergides from University of Toronto. We're moderating this second session on oral abstracts from the clinical sciences. We have a great group of presentations today. You'll note that on the right-hand side, near the bottom, there's a Q&A box, so you can enter any questions you might have. The presenters are going to present for 10 minutes each, and there'll be 5 minutes for questions. There's adequate time to review any questions, so please do feel free to add them. So our first question is, our first presentation is trends in illicit drug use among patients recently treated for hepatitis C in British Columbia, Canada. This is being presented by Lauren Harrison, who is a research assistant at the BC Centre for Excellence in HIV/AIDS. And please take it over, Lauren.
Great, thank you so much for the introduction. Just share my screen here. All right, I trust everybody can see my slides. So hi everyone, my name is Lauren Harrison, and today I'll be talking about trends in illicit drug use among patients recently treated for hepatitis C in British Columbia, Canada. And when this research was conducted, I was a research assistant, but I'm now a research coordinator with the BC Centre for Excellence in HIV/AIDS. And I would just like to begin by acknowledging with respect that the place where I work in Vancouver is on the sovereign lands of the Coast Salish peoples, specifically the Musqueam, Tsleil-Waututh, and Squamish peoples. As well, I have no financial or other conflicts of interest to declare. All right, so in April of 2016, BC declared a public health emergency due to a surge in overdose deaths. And since the time that this was declared, the rate of death due to the illicit drug toxicity has risen 400%. And in 2021, more than 2,200 lives were lost due to a toxic illicit drug supply. And for folks who use drugs, and in particular injection drugs, the burden of the drug poisoning crisis often occurs alongside an increased risk of HIV and hepatitis C, as we know that somewhere around 60 to 85% of new hepatitis C infections are among people who use injection drugs in Canada. So compounding these risks, COVID-19 is suspected to have caused disruptions in harm reduction services, housing, and mental health care that may have exacerbated substance use risk. So this suspected change in substance use risk has not been adequately evaluated in a setting of people who have been recently treated for hepatitis C with direct-acting antivirals. So particularly with the complexities introduced with the COVID-19 pandemic, it's really important that we have a solid understanding of drug use patterns and behaviors in order to respond to the needs of folks at risk for HIV and hepatitis C infection. So in recognizing the importance of understanding and responding to trends in drug use so that we can meet the needs of underserved clients who are uniquely impacted by the overdose crisis and infectious disease, our objectives with this cohort were to first identify temporal trends in the proportions of drugs used among a cohort of people recently treated for hepatitis C, and then also to assess if the COVID-19 pandemic has impacted types of substances used in a sample of clients recently treated for hepatitis C. So the study used the Persevere cohort. It's a longitudinal study assessing hepatitis C reinfection rates, healthcare engagement, and health outcomes among adults who have recently completed direct-acting antiviral hepatitis C therapy. The Persevere study is located in the downtown east side of Vancouver, and our recruitment includes referrals from clinics and hospitals, flyers and posters that are placed throughout the downtown east side, and community outreach activities and events with organizations throughout the Lower Mainland. Participants in the Persevere study complete a baseline survey and follow-up interviews where they also supplied blood work and a urine sample. And at the time that the study was conducted, Persevere had 230 participants with a median age of 55. Most participants were men, with 66% of the cohort identifying as men, 32% as women, and 2% of the cohort as transgender. So for this analysis, we used the urine drug screening results from the Persevere cohort, as well as self-report data from the questionnaire, and our sample was restricted to those with a positive urine drug screening sample. And the substances we were looking at in the urine drug screening sample were cocaine, amphetamines, marijuana, ecstasy, morphine, benzodiazepines, fentanyl, methadone, EDDP, which is a metabolite of methadone, and buprenorphine. So for the first objective, all participants who had completed an interview prior to July 1st, 2021, and had a positive urine drug screening sample were included, meaning that we were looking at the proportion of people using each substance among people who used drugs in that year, and then we analyzed those changes over time. And the time span here was from 2017, when Persevere first began, to 2021. And then for the second objective, participants who completed surveys between March 2019 and March 2020, and July 2020 and July 2021 were included in the pre and post COVID-19 analysis. So looking at Persevere participants who had a positive urine drug screen at their baseline interview, we can get a closer look at the characteristics of our sample. So in this cohort, there were 164 participants with a median age of 52, and the gender breakdown really closely mirrored that of the Persevere study as a whole, with the majority of participants being men. And participants most frequently lived in single-room occupancy accommodations and were located in the downtown east side. About 11% were experiencing homelessness during their baseline survey, and most participants made between $10,000 and $15,000 annually. As well, just to give a brief snapshot of our cohort's use of harm reduction services, most had self-reported use of injection drugs, as well as a supervised injection site in their lifetime. And then just under half had used injection drugs within the last 3 months of their baseline interview. So of those that reported using injection drugs in the last 3 months, 53% had used a supervised injection site, and most of our participants got new rigs and equipment from a housing distribution program. So here are results for the trend analysis, looking at the proportion of illicit substances used among those that had used substances by year. So overall, we had 198 participants who were included in this analysis, as those participants had a positive urine drug screen at any point between 2017 and 2021. So that means that our sample size did fluctuate by year. So in 2017, there were 33 participants, 113 in 2018, 142 in 2019, 113 in 2020, and 42 in 2021. But looking at this graph, we can see that marijuana, which is the navy blue line, began representing the largest share of substances among those who were using substances. But over time, this declined. And then by 2017, 67% of those using substances used marijuana. And then going to 2021, it was 46% with a p-value of 0.042. So this was statistically significant. We can also see a statistically significant increase in ecstasy and amphetamines, represented by the red and green lines respectively. The number of participants in our sample using amphetamines increased from 18% in 2017 to 42% in 2021, with a p-value of 0.022, while the proportion of ecstasy increased from 3% in 2017 to 37% in 2021, with a p-value of less than 0.001. So using a McNemer test comparing urine drug screening samples taken during the 1-year period prior to COVID and then a 1-year period during COVID, we can see that fentanyl had a statistically significant increase pre and post COVID. No other substances were found to be statistically significant. And I just want to point out, it's interesting to see that there was no significant change in self-reported overall non-injection substance use, and injection substance use between the pre and post-COVID timelines. So this study does have some limitations, notably a relatively small sample size. We also were not able to account for factors such as the frequency or method of use. So while we can see patterns of substance use, we don't actually know what caused the changes. So we don't know what specifically about COVID may have caused changes in substance use, and we don't know what factors may have contributed to the changes over time. As well, these findings are specific to a subset of the population who do have some engagement with care. They were treated with direct-acting antivirals within the last 3 months, and we were able to connect with them in the community. So they may not necessarily be representative of this population as a whole. And so some key conclusions from our study is that we saw stimulant use, specifically ecstasy and amphetamines, increased, while the proportion of participants using marijuana decreased. And what we saw was that over time, the difference between the proportions of drugs became smaller. So, the proportion of people using ecstasy and amphetamines became much more similar to the proportion of people using marijuana. As well, fentanyl use increased pre and post-COVID, but was the only substance where we saw a significant change. And finally, our findings do support the need for further research exploring factors such as the method of use to make sure that harm reduction services are being provided to best meet the needs of people who use substances. And just for some acknowledgements here, I want to thank the CAHR conference organizers, everybody here for listening to this presentation today. Thank you so much. All our Persevere participants, collaborators, co-authors, co-workers at the BC CFE, and lastly, our funding sources from the BC Ministry of Health and Merck Pharmaceuticals. Thank you very much.
Thank you very much. That was a very nice presentation. So we have a question whether you think the increase in fentanyl use was due to greater availability or perhaps lower cost?
I think that, there's a lot of different things we can hypothesize for the increase in fentanyl use, and those could certainly be two contributing factors. Something else that I would hypothesize is that people don't necessarily know what are in the drugs that they're taking currently. There's so much diluting, so much. They might not necessarily. They might think that they're taking down, and there might be fentanyl in there. So yes, that could absolutely be contributing, and just the general trend of mixed substances.
And another one. Did you ask participants what drugs they were taking and compare those to the UDTs? I'm wondering if they were always aware they were taking fentanyl.
Yeah, that's a really great point. We did ask people what substances, so we do have that self-report data as well. It's not included at this analysis at this point. We were really just trying to get a snapshot of what is currently happening, and then pushing to those questions of, why is it because people are unaware that fentanyl is in the substance they're using? That's when we would be able to look at those comparisons.
And I note that heroin wasn't in the list. Do you think there's much heroin but it's not picked up by your urine screens?
Absolutely, yeah. So we don't have heroin in the urine drug screening samples, but it would definitely be an interesting substance to include. It is a part of our self-report data, but unfortunately it didn't make it into this analysis.
One other thing is, I note the median age was 55. Is that sort of reflective of the general PWID population in the area you're surveying, or does this tend to be an older population than the general?
Yeah, that's a really good question. I don't have a direct answer for the median age of people who use injection drugs in this geographical area. With the Persevere study, it's including everybody who's been treated for hepatitis C within the last 3 months. So there is, an older cohort within that group, and they may not be using injection drugs, but they would be included in the median age for the whole study. The median age for this particular group was a little bit lower. I think it was 52, but it was still within that age range. So I can't say directly, but it is a little lower than what we got for the whole Persevere cohort.
Well, thank you very much. That was great. So, okay, so next we're going to have the next presentation is David Moore from the BC Center for Excellence in AIDS. The topic is, the title is Access to Care and Impacts on HIV Treatment Interruptions During the COVID-19 Pandemic Among People Living with HIV in British Columbia. Thanks very much, Dr. Moore.
Okay, great. I assume you can see my screen there. So thanks to the organizers for the opportunity to present here. I'm presenting on behalf of my co-authors who are all listed here. And I should mention, I don't have a disclosure slide, but I have no financial or other conflicts of interest to disclose. I'm presenting today from the ancestral, traditional, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, for which I'm grateful to be able to live, work, and play here. So as Lauren mentioned, the COVID-19 pandemic has resulted in many changes in healthcare delivery services, and this is also true for people living with HIV. Specific, to some of the changes that we've seen initially, especially in the first wave, limitations on in-person appointments, options for virtual care were developed somewhat to mitigate the impact of that. And at least in British Columbia, the HIV drug treatment program allowed for sort of longer dispensing intervals for antiretroviral therapy. And of course, there are many other changes that I don't have time to describe here. So in this analysis, we examined perspectives on some of these changes in health service delivery or access due to COVID-19 from people living with HIV in BC, and looked at the potential resulting effects on antiretroviral treatment interruptions. The data for this analysis comes from the Stop HIV/AIDS Program Evaluation Study, or the SHAPE study. We recruited individuals into this study from January 2016 to September 2018. We used purposive sampling to enroll a somewhat representative sample of people living with HIV aged 19 years or older across BC. Participants in SHAPE complete surveys at enrollment, 18 and 36 months after enrollment. And initially, these were a combination of in-person interviews, telephone interviews, or self-completion of surveys online. All participants consented to data linkages with the BC HIV drug treatment program. And similar to other studies, data collection stopped in the first wave of COVID-19 from March to September 2020, and then resumed in October 2020. And for this study continued until August 2021. When we resumed our data collection, this was done only as telephone interviews or online only, with no in-person data collection. And we also added some additional questions about COVID-19. So for the analysis in this presentation, we looked at trends in treatment interruptions in 6-month periods amongst all SHAPE participants between March 2019 and August 2021. And treatment interruptions were defined as being 60 days late or more for an ART refill. And we used data from the BC HIV drug treatment program to determine this. And then we also examined associations of treatment interruptions and reported health service access using generalized linear mixed models amongst participants that completed the COVID questions. So 644 participants were originally enrolled into SHAPE, which included 22% female, or self-identifying as female, 77% as male. Just about half, or just over half of the cohort reside in the Vancouver Coastal Health Authority. 57% self-identified as gay, bisexual, or other men who have sex with men, and 40% reported a history of ever injecting or using injection drugs. As you can see from the map, the SHAPE cohort is generally thought to be representative, at least geographically and from a gender, HIV exposure category perspective, thought to be generally representative of the drug treatment program as a whole. 595 participants were alive and still residing in BC in March 2019 and had been receiving ART for at least 3 months since enrollment in SHAPE. We used data from these 595 to look at overall trends in treatment interruptions. And then 196 participants completed the COVID-19 module survey, and this is the group of participants that are included in our GLM analysis. So this is looking at the overall trends in treatment interruptions over time. You can kind of see that the proportion of people with a treatment interruption in each 6-month period varied between 6 and 7.5% for all periods, except for the last 6-month period, March 2021 to August 2021, where we actually saw a lower proportion of individuals with treatment interruptions. When we look at our test of trend using logistic regression analysis, similarly, we see a lower odds of experiencing a treatment interruption in the final data collection period, but really no significant difference from before COVID to after COVID for the other periods. So when we looked at the participants that answered questions from the COVID module and were on ART for more than 3 months, we had slightly fewer female participants in this sub-study, 17% female, slightly fewer from Vancouver Coastal, 49%, and the proportion of GBM was slightly higher, 68%, and the proportion of people who use injection drugs slightly lower. Overall, amongst these 192 participants, 7.8% had treatment interruptions only before March 2020, 7.8% had treatment interruptions only after March 2020, and 2.6% had treatment interruptions in both periods. When we looked at responses to the health service access questions, we found that 33% reported having difficulty accessing healthcare during COVID-19. Approximately 11% reported avoiding healthcare services during COVID-19, and about 73% reported using virtual healthcare services since the start of the COVID pandemic. So this is our analysis looking at treatment interruptions over time, the univariable and the multivariable model. And again, we see in the multivariable model this reduced odds of having a treatment interruption in the final study period, but really no significant change in the odds of treatment interruptions for the other study periods compared to March 2019 to August 2019. The only other factor we found associated with treatment interruptions was being a current smoker. And interestingly, we did see sort of a trend towards reduced odds of treatment interruptions amongst people that had reported using virtual health services or telehealth, but this was not statistically significant even in the univariable analysis. Notably, we didn't really see any associations between treatment interruptions with respect to age, gender, education level, ethnicity, or challenges to health service access, or any change in substance use related to COVID-19. So our conclusions are that from this analysis is that while some participants reported challenges to accessing services or avoidance of services due to COVID-19, treatment interruptions were not more likely during COVID-19 than before. And in fact, none of the challenges that participants reported were associated with treatment interruptions. As I mentioned, many participants reported accessing virtual health services. Those who did appeared to be less likely to interrupt treatment, but this was not statistically significant. The strengths of our analysis, again, we think the purposive recruitment allows us to recruit a sample that was generally representative of people living with HIV in BC, at least on the items that we tried to adjust our recruitment for. The data linkages with the drug treatment program allows us to follow participants even if they miss or have completed survey data collection. However, as in any cohort study, participants become less representative of the underlying population over time, and only actually 30% of participants actually completed the COVID-13 module, as most people had exited the study by 2020. I wanted to thank the SHAPE participants, the SHAPE team, our peer research associates, co-investigators, collaborators, our steering committee, and all the partner organizations and clinics that assisted with recruitment and data collection. And our SHAPE is funded by the BC Ministry of Health, BC Centre for Excellence in HIV. And I also want to acknowledge the Michael Smith Foundation for Health Research that provides me with some funding. Thanks very much.
Thank you very much for a provocative presentation. It's not exactly what we expected to see. So, but good news nevertheless. I wonder could you just go over a little more how treatment interruption was defined? Was it just not filling a script, not missing a script refill? Was it self-declared treatment interruption? Was it a combination of both?
No, so yeah, our definition of treatment interruption is what's used by the HIV drug treatment program for programmatic purposes. So refill prescriptions are sent out every, for most people, every 3 months from the program. And if those refills are not filled within 60 days after the expected refill date, then that's identified as a treatment interruption. From the program, they actually send an alert out to providers. The patient is late for their refills, but for the purposes of this analysis, we stuck to that kind of 60 days or more late for a refill.
So if the time period is March 2021 to August 2021, and the data collection was until when? Like, I'm just wondering, if someone was supposed to fill something in August, and it wouldn't be until you might not see that until October or November. Was that included in the data collection that long?
Well, the thing is, the data collection for the drug treatment program was continuous all the way through COVID, right? Because that's based on pharmacy refills that continue. That's sort of independent of the SHAPE study. The only data collection that was interrupted was the surveys of the SHAPE participants. So that was interrupted for a 6-month period and resumed in September 2020. So
yeah, if some is by verbal patients saying I wasn't taking for a while, you might miss those. No,
but that isn't. None of this is based on self-report. It's all based on program data.
Do you think that it could be because people are getting 6-month scripts instead of 3-month scripts, and that's why the number of treatment interruptions went down?
Well, so for the most part, like I would characterize it as really no change. The only part where it went down was kind of in that very last 6-month period. And initially, particularly in wave 1, yeah, there was a, as I said, the program allowed for longer intervals. For most people that didn't go to 6 months, it was usually 4 months rather than 3 months. But yeah, presumably that had some beneficial effect on, keeping people engaged in treatment.
Do you think we should be continuing at 6 months even after the pandemic's over?
Well, it's kind of one of those challenges because, it's really kind of a programmatic decision. The general rule from, the Ministry of Health with respect to dispensing medication in general is a 3-month dispensation of everything. So it's not really up to, our program to dictate that. But yeah, it's something to consider.
Do you have any hypotheses why smokers had a greater incidence of treatment interruption?
Well, yeah, we don't think it's a direct effect of smoking. I think smoking is really cigarette smoking is really like a good indicator of kind of, to some extent, socioeconomic marginalization. We know there's, smoking is associated with lower income, increased use of other substances, that kind of thing. It just turns out that it's a very effective marker of those kind of things. And we've seen that with other, in other analyses too, that smoking kind of highlights a particular, people that are still smoking are a particularly, challenged group.
Interesting. Well, thank you very much. It was a very interesting presentation. Okay, so next we have Amit Gupta from the BC Centre for Disease Control. And the topic is access to community anal cancer screening among men who have sex with men living with HIV in the HPV screening and vaccine evaluation, the Hpv Safe Study.
Thank you, Dr. Silverman. I would like to thank the CAHR organizers for letting me present today, and I am coming to everybody from the traditional and unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh people, and I have no financial disclosures to report today. So a little bit of background on anal cancer. Well, anal cancer is a common HPV-associated malignancy in MSM living with HIV. And despite HPV infection being quite common in the general population, anal cancer disproportionately affects MSM living with HIV, with an incidence of about 50 to 100 times greater than in the general population. And some risk factors that are among MSM living with HIV include smoking status, CD4 nadirs under 50, or persistent low CD4s under 500. And it's really this immunocompromising nature of HIV that's driving the increased risk for persistent HPV infection that leads to the downstream effects that lead to cancer. And well, tumors identified in early stages have quite a good prognosis, with about 95 to 100% of cases achieving 5-year survival. Unfortunately, survival falls to around 50% in later stages. And also, anal cancer in MSM living with HIV is often diagnosed quite late. So we're really not hitting those early stage diagnoses, and we're usually falling in these later stages where survival is inferior. Though we know that targeted screening with anoscopy and anal PAPs can identify anal precancers by looking for cellular level changes before the development of cancer, access to these services is coupled with significant wait lists, and it's literally limited to urban centers. So we aim to quantify access to community-based anal cancer screening strategies among MSM living with HIV. And I use the term screening strategies quite loosely because at this point in time, we don't have like this gold standard screening algorithm that all MSM living with HIV should be following. So we're really trying to quantify experiences with a plethora of different screening strategies that we know are being used in the community. So, well, what are the options at play to identify and prevent anal cancer? Well, this is kind of what our menu looks like in clinics right now. And while there's plenty of research happening on biomarkers and other HPV-related testing that could one day be added to this list, this is what's available for patients in clinics today. So on one side, we have targeted screening options, which have the capacity of identifying cancer, but can also diagnose precancers to help risk stratify patient care. So this includes anal PAPs or anoscopy. On the other side, we have these more crude methods of identifying anal cancer. So with simple DARE exams performed by clinicians, or even self-screening for lumps, bumps, and other lesions to maybe trigger a greater investigation in what's going on. Given the lack of guidelines on optimal screening algorithms, there's significant heterogeneity in how different providers approach anal cancer screening. The Hpv Safe Study is a national study examining anal cancer screening among HIV-positive MSM in Canada, with study sites located in Vancouver, Ottawa, and Toronto. So between February 2016 to May of 2021, participants completed a questionnaire assessing prior anal cancer screening familiarity and experience. Participants were recruited via referrals from community HIV practitioners, including some physicians, nurses, and a clinical pharmacist. And descriptive statistics were calculated to report the frequency of targeted and non-targeted anal cancer screening among MSM living with HIV. Access was also then stratified by screening type to understand how patients are being screened, if at all. And in the absence of informing care, I think this is quite important. So among the 750 individuals who completed the questionnaire, the majority were white, over 50, and unpartnered. A minority reported previous awareness of targeted anal cancer screening that is accessible in the community, but most were comfortable discussing health issues related to their anus with their doctor, and most also perceived anal cancer screening as important. But despite being perceived as important, 3/4 of MSM living with HIV had never been previously screened via targeted methods prior to enrollment in HPV Save. Previous experience with screening included either an anal pap alone, so about 8.8% of the population, or an anoscopy with or without an anal pap, so at a higher rate of about 15% of the population. But I mean, ultimately, no targeted screening was by far the most common outcome here, with about 76% of the population falling into that category. Shifting gears to the more crude methods of looking for anal cancer, access to non-targeted screening was much more common than targeted methods of screening, with nearly half of the study population had reported that they previously completed a self-exam for anal lesions, so bumps, looking for bumps and lumps, something like that, at nearly half the population. And about 70% had previously received a DARE exam from a clinician. We then went ahead and limited this analysis to individuals who had never received a targeted method of screening. So among people who had never received an anoscopy or a PAP, nearly 60% received a DARE exam, with an additional 10.7% having previously completed a self-exam without a DARE. So this leaves us with this final slice showing about 30% of MSM living with HIV who had never accessed targeted screening had also never accessed a non-targeted method of screening. So just to reiterate, the majority of MSM living with HIV had received some type of screening, but the most common form by far was DARE. And this is important because there's really no guidelines governing how to screen for anal cancer. So the recent evidence is suggesting that anoscopy and subsequent electrocautery of precancerous lesions can prevent anal cancer. DARE is still the driving force behind anal cancer screening in Canada, and access to these targeted strategies is very limited. Most anal cancers are being diagnosed quite late, and thus that kind of means that lesions have been palpable for some time before diagnosis. DARE allows for the detection of smaller cancers when treatment is more likely to be effective. And in the absence of targeted screening programs, the International Anal Neoplasia Society routinely suggests an annual DARE in all MSM living with HIV over the age of 35. And these DARE exams have been shown to be acceptable and cost-effective in this population, with 99% willing to continue to receive an annual DARE. And I also wanted to touch on the role of self-exams, because I think we seldom talk about this in the context of anal cancer, but nearly half of our population reported a history of self-examination. So this suggests that programming aimed at increasing patient-driven approaches to anal cancer screening would be very well received. Men taught self-examination are able to detect a variety of lesions. And in another study, they found that patients are able to detect lesions as small as 3 millimeters. And that earlier stat I talked about with 95 to 100% cure rates, well, that was occurring with tumors smaller than 10 millimeters. So, I mean, there is logic here for this type of screening. And furthermore, self-examinations are already widely being used in other cancer areas, such as testicular cancer and breast cancer, which self-exam is very common in at-risk populations over there. So to conclude, though anal cancer screening was rare among MSM living with HIV, or at least targeted anal cancer screening, DARE and self-exams were certainly the most common methods that we were seeing in community. And in the absence of widespread access to targeted screening programs, the use of these low barrier services supports the early diagnosis of anal cancer. And given the high proportion of MSM living with HIV who self-screened, these patient-driven approaches could also be quite acceptable in this population. But we do need more studies looking at self-exams to understand the role of them, whether it's monitoring or for primary detection, or especially to understand the efficacy of this method in the population. I thank everybody for paying attention, and I'll hold for questions. Thank you.
Thank you very much for dealing with an important subject that doesn't get enough attention. A question was: are there any online tools to teach how to do self-anal exams?
I wish. There are, as far as I know, there are not currently available, but that is a good idea for us to work on. So I appreciate that.
Right. And what was the average? I'm wondering what was the average age of the patients, because I see a lot, as you point out, a lot had DARE. I'm wondering if it's an older population, were they having DARE because people were looking for prostate cancer and that's why they were getting it, or were they?
That is a really good point. I mean, I think the majority were over 55. I think the average age was about the mean age was 50 even, and so it is a slightly older population. I guess that's all relative, but 50 is the mean age. So yes, it's possible that it was looking for prostate exams, but we were also looking for anal cancer, I guess.
That's the advantage of DARE, is it for both things rather than just anal cancer. Do you know, is there any literature out there? I have limited knowledge about breast self-exam, but my understanding is that it's being de-emphasized because of the number of false positives that come up and the increase in anxiety that it leads to, without necessarily picking up many. So and others in the audience may know better, but my understanding is being de-emphasized. I'd imagine, because you can't look, people are going to be feeling a lot of hemorrhoids and a lot of other things when they do a self-exam, because unless you got a mirror, it's very hard to see what's going on down there, or unless you're very flexible. So is there any evidence that self-exam actually is helpful?
Yeah, I think it's a good question. And I mean, I think it's important to, I guess with breast cancer, the difference is we have quite good access to mammograms. In contrast with anal cancer, I guess we have quite low access to anoscopy, because there's probably like under 10 providers in the country that do this. And PAPs are our second best thing that we have right now, and PAPs aren't great either. So to answer your question, no, there's no study that has particularly assessed this. There's actually only been one study that's ever looked at self-exams in Australia, but it's an important area of research that I think should be assessed further in the future.
Yeah, and so was there any? I guess in your study you wouldn't have any patient, maybe in other parts of the study, patient satisfaction with the procedure and all this.
Correct. Yes, we do collect that data, and it has not been yet analyzed. So stay alert for that data when that comes out soon. Okay.
And then another question just came up from Ron Rosenis, and I apologize if I pronounced the name wrong. I worry that DARE and self-examination may miss catching pre-anal cancer conditions. Do you think we should be doing more to advocate for improved access to anoscopy? And I would add, to my knowledge, that's the only procedure that's been demonstrated in a trial to actually make a difference.
Correct. Yeah. So that is like quite hot off the press. It is the Anchor study that recently came out that found that result. That is a good point. And I think it's important not to look at this as like an either or situation. Like you just mentioned, like DAREs have advantages for looking for prostate cancer as well as anal cancer. So while increasing access to anal cytology or anoscopy are certainly priorities, I think it's also kind of thinking about what we have access to today and what can we do today. And while anoscopy might be the future, today we have quite easy access to DARE with it's very accessible in community, especially in rural areas where that anoscopy is quite challenging to access out there. So maybe not looking at them as either or, but trying to emphasize both in the best ways that we can.
Thank you very much.
Thank you.
Okay, so next we have Dr. Amin Benmasoud from McGill University, and he's going to present on non-invasive prediction of liver-related events and death in people with HIV.
Thank you very much, Dr. Silverman, for the introduction. And it's really an honor for me to be here today presenting to you our abstract entitled Non-Invasive Prediction of Liver-Related Events and Death in People with HIV. So as you all know, liver disease carries a significant burden in the HIV population. It's actually the #1 chronic morbidity above cardiac diseases, kidney disease, and cancers. It's diagnosed in about 1 in 7 individuals. It's also a leading cause of mortality, coming third after AIDS-related illnesses, non-AIDS cancers, and then comes liver disease at 13%. So how does one with HIV have or develop liver-related events? As you well know, these individuals are often co-infected with other viruses, including hepatitis C and hepatitis B. Furthermore, the presence of metabolic syndrome or comorbidities also increase the incidence of non-alcoholic fatty liver disease in this population. Furthermore, some of them also with substance abuse issue and alcohol-related liver disease can also develop. All these together with inflammation and further scarring or fibrosis can lead to the development of advanced liver disease. With that will come portal hypertension and ascites, hepatic encephalopathy, or variceal bleeding. Another less common pathway is through the HIV virus itself, or the use of antiretroviral medication and their liver toxicity, which would pass through the non-cirrhotic portal hypertension pathway, but will also lead to the same complications. Not to forget, those with advanced liver disease or cirrhosis can also develop liver cancer, such as the hepatocellular carcinoma. Therefore, it's really important to develop screening strategies to identify these individuals before these complications occur. So what are these non-invasive strategies or screening tests that we have? Well, we're laboratory values, including liver enzymes or liver function tests, and also looking at platelet count, where low platelets could signify or show the presence of portal hypertension. Abnormal abdominal imaging, obviously, if it documents the presence of cirrhosis on ultrasound or CT, but also splenomegaly. Then more recently, the advent of transient elastography, which is a physical method using this machine that you see on the left-hand side, which is able to quantify liver stiffness. And the stiffer the organ, the more likely there is to be advanced scarring or fibrosis. These can also be put together to develop risk scores. Obviously, these are all indirect markers, but they have been very well validated in patients with cirrhosis. Now you can wonder whether or not this could overestimate the disease burden in HIV, where low platelet count or splenomegaly can be due to other things but liver disease. So what are the combination scores that are available to us going from left to right? First one is the liver stiffness measurement alone that I just described by transient elastography, or you can also add platelet count, getting you the liver stiffness to platelet ratio, so LPR. If you add spleen size, well, that you have the LSPS score, or the portal hypertension risk score, if you also include the sex of the individual. These have already been very well validated to diagnose the presence of portal hypertension, where LSPS and the portal hypertension risk score seem to be doing maybe a bit better than liver stiffness measurement alone. But this, unfortunately, has only been validated in patients with compensated cirrhosis due to hepatitis C or alcohol, but not in those with HIV. Therefore, there's a really huge unmet need right now to develop a tailored approach with the use of non-invasive tools in this patient population. So the aims of our study was first to determine the incidence of liver-related events in people with HIV, and then to propose novel cutoffs using these non-invasive tools to predict these events. And then we evaluated these predictors. In terms of study design and methods, this was a retrospective multi-center cohort study with centers collaborating in the SHIVR network. Participants to be included needed to be above the age of 18 and have a diagnosis of HIV and available liver stiffness measurement. We've excluded all those with unreliable liver stiffness or previous liver event. Then we looked at outcomes of interest, specifically the development of ascites, variceal bleeding, hepatic encephalopathy, or hepatocellular carcinoma, and death. Then we evaluated these non-invasive tools, specifically looking at liver stiffness measurement, LPR, LSPS, and the portal hypertension risk cohort to see if they could predict our outcomes of interest. In terms of statistical analyses, we calculated the incidence rates for these liver-related events and grouping individuals based on the presence of thrombocytopenia, defined as a platelet count below 150, or the presence of advanced liver disease with a liver stiffness measurement above 10 kilopascals. We then determined non-invasive cutoffs using the Untitled index to maximize sensitivity and specificity to predict liver-related events or death, and then evaluated these predictors using a multivariate Cox regression analysis with a priori determined variables. And then present our data with 95% confidence interval and statistical significant at p-value below 0.05. So overall, 1,549 individuals met inclusion criteria, but then 61 had to be excluded because unreliable liver stiffness measurement in 52, and 9 of them also had previous liver event at baseline, which gives us a final cohort of 1,488 individuals. Because this was a multi-center cohort study, this is how the participant, where they came from. So about 500 came from Bordeaux in France, 420 came from our center at McGill, Montreal, Canada, 370 came from Seville in Spain, and then we had other centers contributing from the Royal Free and Imperial College, both in London, UK, Bonn in Germany, Modena in Italy, and UCSF in San Francisco. So sort of our table of one. And just to draw your attention, really the typical participant was a middle-aged individual, more often male, with a long duration of HIV. Most of them were also co-infected with hepatitis C, but still had quite good control of their HIV disease with undetectable viral load in about 70% of them. Not only that, but there was quite high prevalence of advanced liver disease as diagnosed with liver stiffness measurement above 10 kilopascals in about 40% of individuals, and splenomegaly and thrombocytopenia were quite frequent in about a third each. Now we turn our attention to the occurrence of liver-related events, and this is where we group them based on the presence of thrombocytopenia and advanced liver disease. So first, at the far left in group 1, and this were those with normal liver stiffness and normal platelets, really see the incidence of liver event was minimal at about 1 per 1,000 person year. Then group 2, and already we could see an increase, significant increase in the incidence of liver-related events, were those that just had thrombocytopenia, so a platelet count below 150, but a normal liver stiffness. Following that in group 3 were those with abnormal liver stiffness and normal platelets, and group 4 with highest incidence at about 40 per 1,000 person year were those with both abnormal liver stiffness and thrombocytopenia. This is another way to look at this through a Kaplan-Meier curve, where you can see the same groups again differentiating. Then we moved on to develop non-invasive cutoffs for liver-related events and death for all 4 non-invasive tools that I've discussed. And as you can see, the area under the curve for all 4 of them is very similar. We've then moved on to develop the Untitled cutoffs that we were proposing using each one of these methods. And all of them had quite good sensitivity, really allowing you to exclude the occurrence of these events. Then we moved on to looking at the predictors using a multivariate Cox regression analysis. And so this is the first model looking at liver stiffness measurement using the cutoff that we had just determined. In model 2, this would be also looking at with the liver stiffness to platelet ratio. Model 3 is with LSPS. And finally, model 4 is with the portal hypertension risk score. And as you can see, in all 4 models, the non-invasive tools that we have evaluated were all significant predictors and that independently. And as you can see, duration of HIV and co-infection status were not significant predictors when we've included the non-invasive tools. In the models 1 and 2, where there was no spleen diameter that was included in the actual non-invasive test, you can see that bigger spleen was also predictive of liver-related events and death. So in terms of strength, this is a very large international cohort, really putting in together nearly 1,500 individuals using prospectively maintained database. And really our goal is to really propose a simple approach to guide clinicians. And I think that's something that we were able to do. In terms of limitations, well, unfortunately, all the centers involved here are tertiary care centers with obviously a referral bias. and which could also explain why there was such a high prevalence of advanced liver disease at 40%, as you saw in Table 1. Unfortunately, because this is a retrospective cohort study, some individuals did not have spleen size determined, as it might not have been requested by their treating physician. And obviously, if there were some really minimal ascites that would have been missed on physical exam, that might lead to possibly underdiagnosing certain events. But so in conclusion, I think with really a simple risk stratification with a platelet count below 150 and or an abnormal liver stiffness measurement above 10 kilopascal, really able to identify a group of individuals at higher risk of developing liver-related events. Furthermore, the risk scores that we've looked at, including liver stiffness measurement, liver stiffness to platelet ratio, LSPS, and the portal hypertension risk score, were all significant predictors of liver-related events and death, and is independent of duration of HIV and co-infection status. And therefore, using this, really would recommend screening all individuals with HIV using these non-invasive approach to identify cases earlier. And so I'd like to thank all of our collaborators for their participation, and obviously the audience for listening in. Thank you.
Okay. Thank you very much for an interesting presentation. So a question from the audience was, how easy would it be to implement this clinically?
Right. So, and I think this is one of the limitations as well, because we are doing tertiary care centers. A lot of these non-invasive tools that we've looked at had liver stiffness measurement in their backbone, and so this you'd need a specialized clinic where liver stiffness would be available. But I think beyond that, as I was trying to show as well, simple blood count, simple CBC or a platelet count below 150 already identifies a subgroup of individuals at higher risk.
So I wonder if you could explain, because all these patients had access to, FibroScan, transient elastography. So if you already have, but you're reporting this as, less than 10 or greater than 10, when normally we look at a FibroScan and we'll say less than 7.2, 7.2 to 8.8, and we have all these gradations. And if you're, did you look at just comparing, FibroScan, scoring it as F0 to 1, F1, F2, F3, F2, F3, or F4, and whether this is just a fancy way to say this is F4, because if you already say, well, this is simpler, but these patients already have a FibroScan, which already is quantitative, and we're not using that quantitative information, so it's going to be better than just a less than 10 or greater than 10, or less than 15.9 or greater than 15.9. But really the question is it better than the FibroScan as we traditionally use it, which breaks things up into F0 to F1 all the way up to F4, and then within F4 to extremely high levels of fibrosis, which we know have very high risk, and we're throwing all that information out.
Absolutely, I think that's a great point. The reason why liver stiffness measurement above 10 was initially chosen, because that's what's been recommended by the Baveno criteria, looking at portal hypertension, which is really the main driver of these events of ascites, cephalopathy, and bleeding. And they really do say that using liver stiffness of 10, it allows you to diagnose what we call compensated advanced chronic liver disease, or CACLD, which, as you said, it really is a fancy way of calling advanced fibrosis F3 to F4. And so, of course, if we look at those with liver stiffness above 10, we will identify individuals that are at higher risks. And I think, moving though beyond that, and I think that's the case in people with HIV, is that even without this advanced fibrosis, a lot of them might have non-cirrhotic portal hypertension, which might be very subtle in its presentation, which might just be with a lower platelet count. And I think that's why we should not minimize low platelet count in people with HIV, even with a normal FibroScan.
And that's a very important point. Thank you for saying that. So did you look at any other thing? There's the AST to platelet ratio, the APRI, there's the fibro test, there's all these other non-invasive things that particularly the AST to platelet ratio, which is relatively easy, most places can get that. Whether that can add anything further above just a low platelet count?
Absolutely. And so I think this is where we're going to go next with the analysis. As you saw, we provided 4 different models with 4 different non-invasive tools. And I think the point will be to identify the simplest way for clinicians. Even using an approach without liver stiffness measurement or without FibroScan, purely on simple to access laboratory values, and maybe with an additional tool to complement that. That are the next steps, yes.
No, very good. It's important stuff. Okay, well, thank you very much. And I think Dr. Sergides is going to take over from you.
Thank you, Mike. So great presentation so far. Thank you to all our presenters. So we'll move on to our next presenter, Giada Sebastiani, who will present her presentation titled Two-Tier Care Pathway for Liver Fibrosis Associated to Non-Alcoholic Fatty Liver Disease in 1,749 HIV mono-infected patients.
Thank you very much for the kind introduction, Madam Chair. And I would like really to thank the organizer for providing us the opportunity of presenting our data, which I do on behalf of 2 other centers, one in Canada and 2 centers in Italy. So these are my disclosures. So NAFLD is a frequent comorbidity in people aging with HIV, but only a proportion of these patients has actually liver fibrosis. And in the continuum of the NAFLD term umbrella, we have 2 main clinical and pathologic entities, which are NAFL or simple steatosis, characterized by fat into the liver, and NASH or non-alcoholic steatohepatitis, which is characterized by fatty liver, but also inflammation and ballooning. And NASH is a condition which can eventually lead to significant liver fibrosis or NASH with scar tissue, cirrhosis, and end-stage liver disease, eventually leading to death and need for liver transplant. In people with HIV, there are specific characteristics in terms of pathogenetic factors leading to NAFL, NASH, and significant fibrosis, cirrhosis. Because people with HIV have more frequent universal factors characterizing the pathologic spectrum of NAFLD, like metabolic comorbidities or gut dysbiosis. On the other side, they have also factors which are unique to HIV, specifically the prolonged use of ART, which can lead to lipodystrophy and hepatotoxicity, and also HIV direct effects like can add actually hepatocyte injury and apoptosis, and also the chronic inflammation that is due to HIV. Because of that, if we compare the prevalence of NAFLD, NASH, and liver fibrosis between the general HIV uninfected population and HIV infected population, you see that all the spectrum of the disease within the NAFLD term are more frequent in people with HIV. And I would like specifically to drive your attention to the more frequent prevalence of significant liver fibrosis, which, as we said, this will eventually lead to cirrhosis if no intervention is taken. So the diagnostic tools to diagnose NAFLD-related fibrosis can be divided roughly into 3 main categories. One is liver biopsy, which is the standard of reference to stage liver fibrosis, however, is invasive, painful, and costly. The others are serum biomarkers, and they were already mentioned in the previous session, APRI, for example, FIB4, and the FibroScan or transient elastography. I would like just to drive your attention first on how to use simple fibrosis biomarkers to diagnose significant or advanced liver fibrosis, for example, the FIB4. You can see here that FIB4 is based on simple parameters which are easily available in the clinical practice of HIV medicine, and a FIB4 score less than 1.3, for example, has a very good negative predictive value to exclude advanced liver fibrosis at 95%. But also FibroScan, its transient elastography, is also a non-invasive tool which is widely used to screen for NAFLD-related fibrosis. And it has been specifically validated in the setting of HIV infection with good sensitivity and specificity. Of note, recent guidelines recommend screening for NAFLD-associated liver fibrosis in at-risk populations. You can see that the European Association for the Study of the Liver, the European Association for Diabetes and Obesity recommend, for example, screening for fibrosis in patients with diabetes and metabolic syndrome. In 2019, for the first time, also the American Diabetes Association has recommended screening for fibrosis in patients with type 2 diabetes. And because we have seen very high rates of significant fibrosis in people with HIV, the guidelines of the European AIDS Clinical Society have also recently recommended screening for NAFLD-associated liver fibrosis in people with HIV. So the aim of our study was to evaluate a two-care pathway using simple fibrosis biomarkers and FibroScan for the identification of significant liver fibrosis in people aging with HIV. Specifically, we looked at the reduction in the FibroScan referral rate and related cost, and the discordance rate and associated factors of low simple biomarkers and elevated FibroScan. So those patients where the biomarker would indicate absence of fibrosis, but our FibroScan would actually indicate presence of fibrosis. So we used 3 cohort studies that are prospectively investigating NAFLD and fibrosis in people with HIV. The first is the liver HIV cohort, which is a prospective CAHR funded cohort investigating NAFLD and fibrosis in people with HIV, and other 2 cohorts internationally collaborating with the liver HIV, which are the Modena metabolic cohort and the Palermo cohort. The 3 cohorts together have almost enrolled 2,000 people with HIV. And you can see here that within the cohorts, we have found significantly higher prevalence of both NAFLD and fibrosis. So this was a cross-sectional study of consecutive people with HIV enrolled from these 3 cohorts. We included patients aged more than 80 years old and HIV positive. Exclusion criteria included failure or unreliable FibroScan and lack of variables to compute our simple fibrosis biomarkers. We also excluding HCV or HBV co-infected patients or those with significant alcohol abuse because we were looking for NAFLD. So the outcome measure was defined as significant fibrosis, which was FibroScan more than 7.1. And we looked specifically at the discordance between the serum biomarkers, low biomarkers, as you can see here in the cutoff, and high FibroScan, and also the proportion of saved FibroScan and also the cost that we would save if we would use simple fibrosis biomarkers before the FibroScan. So this is the characteristics of the study population. You can see again, in this large cohort study of 3 cohorts internationally, we found a high proportion of NAFLD in patients with HIV and also a high proportion of significant liver fibrosis. You can see here also the general characteristics of the 1,739 patients that we enrolled in terms of age, sex, ethnicity, diabetes percentage, BMI, and also time since HIV diagnosis, CD4, and also triglyceride and ALT. And you can see here that the classical one-tier pathway that we would use usually, so refer all patients for a FibroScan, for example, and this would really be that all patients are referred to the pathology clinics and the tertiary care to undergo the FibroScan, would be actually substituted in this two-care pathway that we propose by another step, which is first a step with a simple fibrosis biomarker, and then only patients with high serum biomarker would be referred for the FibroScan. And here you can see in terms of the fibrosis biomarkers that we looked for, were the FIB4, APRI, the AST to ALT ratio, the BART score, and the NAFLD fibrosis score. So here you can see how much decrease in FibroScan referrals we will actually obtain by a two-care pathway. And I would like specifically for you to drive the attention on the FIB4, which will lead to a 63% decrease in FibroScan referrals, and the APRI 86%, which held the highest yield in terms of decrease in FibroScan referrals. And also the APRI had a very good low discordance rate between high FibroScan and low fibrosis biomarker if we compare with the number of FibroScan saved. So these results would actually save €9,766 if we would perform fibroscan in all patients, but if we use the 2-care pathway, we would save really a very important proportion in terms not just of fibroscan, but also of cost, because the total cost saved would be between 63% and 86%, according to the simple biomarker used as first hire. And here you can see which were the predictors of discordance between low biomarker and high fibroscan. We studied specifically by logistic regression analysis, APRI and FIB4, because these were the biomarkers hidden to the highest ratio between the fibroscan saved and the low discordance between fibroscan and biomarkers. And the two predictors that emerged in both cases were higher BMI and higher triglycerides. I would like to acknowledge some limitations of this study. Specifically, we didn't have availability of liver histology, which is the gold standard. We didn't perform a cost analysis accounting also for the cost of cases with fibrosis missed by serum biomarkers. And we didn't have longitudinal data to assess the effect of early identification of significant fibrosis on clinical outcomes. So in conclusion, a 2-tier care pathway uses fibrosis biomarkers as first tiers, could save up to 86% of fibroscan and care costs, helping resource optimization in HIV clinics and low resource settings. Similar to NAFLD in the HIV and infected population, APRI and FIB4 seem the most promising first-tier tests. Patients with overweight or dyslipidemia may still be considered for fibroscan examination, even in case of lost serum fibrosis biomarkers, because these are the predictors of a discordance between fibroscan and serum fibrosis biomarkers. And I believe the future studies should focus on the longitudinal and long-term effects of the large-scale application of these models of care. So I would like really to thank you for your kind attention, and I'm happy to take any question.
Thank you, Giada. That was a very interesting presentation. I have a couple of questions for you right off the bat, and I'm encouraging the audience to put their questions into the question Q&A section. I noticed that your sex variable was marginal. It almost hit significance for one of your biomarkers. Did you see any, and I know that you had not as many women as you had men in your study. So do you think there is a difference between males and females for how good these biomarker predictors are?
I think this is, Lena, this is a great question, actually. I don't have the answer because, as you said, unfortunately, until now, we were not able to enroll a significant proportion of females in the cohorts. But in the prospective study that we are conducting, funded by the CAHR, we actually aimed at including at least 35% of females in our study. In fact, we have also Sharon, who is a gender champion, as we all know, Sharon Walmsley, among the investigators. And I believe that this is a very important research question because to specifically validate these biomarkers, especially the serum biomarkers in females, because, for example, we know that there are changes in the fibrosis progression in females at different ages. While usually fibrosis progresses fast in males before, the menopause of women, after the menopause, we actually see several studies have shown that the natural history of the disease changes after the menopause because of the protective effect of the estrogens, and fibrosis accelerates in women after the menopause. So I think this is a crucial point, and I hope that I'm going to be able to answer with the prospective cohort that we are running.
Well, I really appreciate that you're thinking about it too. So that's great. One more question is, do you think you used the biomarkers individually, you assess them? Is there any benefit to having 2 or 3 sets of these biomarkers? Are they more predictive and cost effective? I'm concerned about that 11% that you're missing. I mean, what is the cost of that?
I think this is actually a great point, Lena. So, for example, there are some of these biomarkers we didn't test the combination because we were basically basing on a 2-tier, but several guidelines, including the ACTS, for example, recommend always the combination of at least 2 biomarkers. So APRI and FIB4 have similar, as you know, similar parameters, but the FIB4 has on top of the APRI as the AST and the age. So it is possible that the FIB4 should encompasses also what the APRI tells us. However, for example, the NAFOR fibrosis score encompasses also the BMI, which is not encompassed by the FIB4. So I think it's something that we could look in our data. I think it's a great idea, actually. Thank you.
And we have a question from the audience. Any idea about the cost of biomarker missed cases? And also in Ontario and much of Canada, FibroScan is not covered by Medicare. Any idea of benefits here?
Yeah, I think it's also a great question. So as I said, among the limitations of our study, we didn't conduct a cost analysis of the missed cases due to the discordance between the biomarkers and the FibroScan. Because we are looking at huge numbers, as we have seen, I mean, up to 40% of people with HIV have NAFLD. I think we should still consider, even a negative predictive value of 95%. In our case, there was a discordance of 11%. It's still something that we have to do the cost-effective analysis for sure, but I think in big numbers, we have to try to implement these screening guidelines in people with HIV, because more and more we are looking at, we are seeing patients with advanced fibrosis, advanced liver disease in our clinics. But I absolutely agree. Unfortunately, FibroScan is not available in all the practice of HIV medicine. And that's why I think that these biomarkers may be imperfect, may miss some patients, but it's still a step that we can use if we don't have availability for FibroScan for all of these patients.
Absolutely, that's a great point. Thank you very much for that excellent talk. Yeah. And we move on to our next presenter, Hardik Ramani, who will present his presentation titled IL-32 induces a chemokine signature in CD4 positive T cells linked with persistent inflammation and cardiovascular disease in people living with HIV.
Thank you very much. Am I audible?
Yes, you are.
Yeah. Thank you very much. First of all, I'd like to thank the CAHR committee and the organizers to giving me this opportunity to present my work on this conference. Today, I'm going to present the IL-32 induce a chemokine signature in CD4 T cell linked with persistent inflammation and cardiovascular disease in people living with HIV. As we know, combined antiretroviral therapy has greatly reduced mortality and morbidity in people living with HIV and ameliorated the quality of life in them. But in people living with HIV, long-term viral suppressive treatment does not normalize the mediators of elevated and systemic immune activation. Also, this development of inflammatory, degenerative, dysfunctional, and non-malignant non-AIDS defining disease has been generated, also known as comorbidities, such as cardiovascular disease. This persistent production of wide spectrum of pro-inflammatory cytokines, such as TNF-alpha, IL-1 beta, etc., contributes to the disease progression. This chronic inflammatory process promoting atherosclerosis represents a very complex interplay of lymphocyte and macrophage activation, damage to the mucosal barrier, and other factors directly or indirectly related to the HIV replication. Furthermore, this chronic inflammation leading to the atherosclerosis or cardiovascular disease has one common pro-inflammatory cytokines involving, which is IL-32. In earlier study, in people with coronary artery disease have shown that in CD4 T cell, in atherosclerosis or in cardiovascular disease patient are producing interleukin-32 in CD4 T cell, macrophage, and endothelial cell and smooth muscle cells. So before I go further, I'd like to briefly introduce the IL-32 or interleukin-32. Interleukin-32 is a multi-isoform pro-inflammatory cytokine produced in higher class mammals, interestingly, not in rodents. IL-32 is expressed in at least 10 isoform by alternative splicing. Interleukin-32 is produced by immune cells such as the CD4 T cell, monocyte, CD8 T cell, neutrophils, macrophages, etc., and non-immune cells such as fibroblasts, mesenchymal cells, endothelial cells, or epithelial cells. IL-32 is predominantly intracellular, but some literature suggested that IL-32 gamma can secrete in a small amount. Before we go further, the IL-32 gamma is the longest and most inflammatory active isoform. Mainly inflammatory, induces varieties of pro-inflammatory cytokines. IL-32 beta is the most dominant isoform among all and promote vascular inflammation and induce the production of various pro-inflammatory cytokines. On the contrary, IL-32 alpha is the shortest and less active isoform and possesses anti-inflammatory properties. Here we can see in this diagram that varieties of IL-32 isoform induces the multiple function by producing varieties of pro-inflammatory and anti-inflammatory cytokines as well as chemokines. In our earlier study from Canadian HIV and aging cohort study for men and V's women's intelligency HIV study, we have shown that in HIV positive individuals, all the IL-32 isoform has been significantly upregulated. Furthermore, in addition to that, in men, specifically the people with plaque positive individuals in HIV positive patients have shown that specifically IL-32 alpha, beta, and epsilon were upregulated in men on addition to all this thing, all this isoform. And in women, IL-32D and theta were significantly upregulated. From this information, we had mainly two objectives. First, to study the impact of IL-32 isoform on CD4 T cells activation and the potential to recruit the other immune cell to the site of inflammation in vitro. Second, to validate the function on primary cells from HIV positive individuals with and without CVD from Canadian cohort of HIV and aging study. To fulfill this objective, we have isolated the CD4 T cell by negative selection and stimulated with the mainly 3 IL-32 isoform, alpha, beta, and gamma individually. We selected these 3 isoforms because these are the only commercially available isoforms in the market right now. So we stimulated there for 12 hours to understand to see the earliest impact of IL-32 isoform on CD4 T cell. After 12 hours, we have extracted the RNA and performed the total RNA sequencing. After performing total RNA sequencing, after acquiring the result, we have performed a systemic analysis from that result and validated the significantly upregulated modulated genes with RT-qPCR and ELISA for the protein validation. Further, we have validated the significantly modulated genes in significantly modulated molecules in HIV positive, negative, and with and without cardiovascular disease individuals. So from the total RNA sequencing data, we have observed that the IL-32 isoform distinctively impact on the CD4 T cell. CD4 T cell total RNA sequencing showed that individual IL-32 isoform have a distinct impact on CD4 T cell gene transcription. Furthermore, by performing systematic analysis of significantly modulated genes, showed that 1080, 522, and 604 genes were significantly modulated in CD4 T cell stimulated by IL-32 alpha, beta, and gamma respectively. Among them, only 39 genes were significantly and commonly modulated by IL-32 isoform stimulated CD4 T cells. From the systemic analysis and top modulated genes, a chemokine signature we have selected from the top 100 upregulated genes. In compared to non-stimulated cells, alpha, beta, and gamma have shown this particular signature of chemokines significantly upregulated in CD4 T cell after stimulation. Furthermore, after receiving this particular signature, we have validated that signature at RNA transcript level after 12 hours with N is equal to 16 patients. In this analysis with specific primer, we have observed that CCL22, CXCL1, CXCL8, and CCL1 significantly modulated by IL-32 beta and gamma. 4 out of 7 chemokine candidates were significantly upregulated, but CCL24, CXCL5, and CXCL2 were not significantly modulated. Further, in significantly upregulated genes, we wanted to validate the chemokine expression at protein level. So we further validate this particular, we have collected the supernatant and performed the ELISA to see the expression at protein level. And we observe that CCL22, CXCL1, and CXCL8 were significantly upregulated protein expression in supernatant after the stimulation. CCL1 were non-significant in protein production. So only 3 out of 4 chemokine candidates were significantly upregulated by beta and gamma at the protein level. Further, after validating this particular expression at RNA and protein level, we wanted to correlate with HIV individuals. So we performed ELISA in the plasma of HIV positive, HIV negative, with and without cardiovascular disease individuals. Among them, only CCL22 was significantly higher in plasma from R-treated individuals from the aging cohort compared to the control group. However, CXCL8 and CXCL1 have showed the tendency of upregulation in our study. To summarize this result, in our in vitro activation of T cells with IL-32 isoform beta and gamma, but not alpha, upregulates multiple chemokines, including CXCL1, CXCL8, and CCL22. Among these chemokines, CCL22 was the only one to be significantly upregulated in plasma from HIV positive compared to HIV negative individuals. However, CCL22 levels were not different in HIV positive individuals with CVD compared to their counterparts without CVD. Although CCL22 might not represent an ideal marker for cardiovascular disease in HIV infection, although it may contribute to the disease progression. IL-32 alpha showed a non-significant tendency to decrease chemokine production, showing an anti-inflammatory role, as we previously reported. So to conclude this result, the upregulation of CCL22, CXCL1, and CXCL8 by IL-32 in activated T cell, if happening in plaque-forming site in arteries, is likely to promote the recruitment of inflammatory neutrophils, T cell, and monocyte, which could be exacerbate local inflammation and cardiovascular disease. Thank you so much for your attention. And at last, I'd like to thank all our collaborators, my supervisor, and our funding agency, and the CAHR committee for giving me this opportunity. Thank you very much.
Thank you, Hardik. Nice presentation. Okay, so I encourage questions from the audience, and I have a couple for you. I'm not very familiar with IL-32, so this was a learning experience for me. But you mentioned that IL-32 is mostly intracellular, right? It's rarely secreted.
Yes.
So do you think the way that you set up your experiment, where you're adding IL-32 to the T cells, assuming that it would be secreted, the interaction in vivo, is that the best way by which to mimic the in vivo scenario?
That's a very good question. Thank you very much for asking this. In case of inflammation, in chronic inflammation in HIV individuals from our study, we have observed that IL-32, although predominantly intracellular, but majorly they came in contact, and also there are some all varieties of cell in immune system of human being are responding to the IL-32 extracellularly. That suggested that just not intracellularly, but also there is an impact of IL-32 extracellularly, which can be happen by apoptosis during the chronic inflammation, can be happen by pyroptosis, and other mechanism by cellular damage as well. And they can impact the that can impact the chronic inflammation further.
So you think IL-32 is only released extracellularly if there's a cell death situation?
Cell death as well as pyroptosis.
Okay, so the cell has to be damaged in order to release the IL-32.
Yes.
That's interesting. So are you planning to do anything else beyond CD4 cells? It sounds like a lot of cells produce this IL-32. Which cells are responding to it? Is it just CD4 cells, or?
No, all cells, all immune cells, majority of our immune cells, as I mentioned earlier, that CD4 T cells, CD8 T cell, monocyte, macrophage, neutrophils, B cells, these all cells are responding to, in our study also the one of my colleagues is working on endothelial cells from coronary artery. The endothelial cells are also responding from like higher upregulation of IL-6, TNF alpha, and other inflammatory cytokines after stimulation with IL-32.
So that's interesting. So in the context of cardiovascular disease, perhaps looking at like monocytes would be,
yes,
something that would lead like connect better to a cardiovascular disease?
Certainly. We are right now at present, we are trying to understand the impact of different IL-32 isoform on our total immune system and contribution in HIV as well as in cardiovascular disease. My one project is dedicated to CD4 T cell, another project is dedicated to monocyte, and I am moving forward with this thing. So that is my another part of my project in case of monocyte. But it is very interesting to see in case of monocyte, and all the isoform has a very differential and distinct impact on each cell types. And these particular cytokine were upregulated in all HIV individuals.
Okay, and just one last, and it's my naivety now. So is IL-2 interacting through a receptor, IL-32 receptor?
Since the discovery of this particular molecule, we are not able to find out the receptor so far. So we don't know the receptor. Our lab is working over it from past 2 years, but still it is difficult to find a receptor in this particular regards.
Okay. Well, thank you very much. It's nice to be at the beginning of a research area. Lots of questions to ask and address.
Yeah, certainly.
Okay, thank you, Hardik.
Thank you very much.
Our next presenter is Clara Van Omen from UBC, and she's going to present on lower AMH levels are associated with HIV status in reproductive aged women and shorter LTLs in women of late reproductive age.
Hi, everyone. Thank you, Dr. Segedis, for that introduction. I'd like to just start by thanking the conference organizers for inviting me here today, acknowledging my co-first author on the project, Dr. Shea, as well as the other co-authors. And with that, we'll get started. So first, some background on the reproductive health of women living with HIV. First, in terms of fertility, we know that women living with HIV describe wanting to have families, but there's some evidence to suggest that they may have diminished fertility compared to controls. Next, in terms of menopause, the evidence is conflicting, but there is some evidence to suggest that women living with HIV may have an earlier menopause transition, and we certainly know that they do have worse menopausal symptoms. For all women, an earlier menopause transition is associated with increased morbidity, and this is of particular importance for women living with HIV, because we know that people living with HIV are at an increased risk of age-related morbidity, and understanding any increased risk conferred to women living with HIV because of an earlier menopause transition is important for their care. So this altogether paints a picture of a premature reproductive aging phenotype in women living with HIV. To explore this further, we wanted to examine both markers of cellular aging and ovarian aging in women living with HIV. So first, LTL, or leukocyte telomere length. So telomeres are redundant DNA at the end of chromosomes that shorten as we age, and telomere shortening is an accepted theory of aging. And we do know that people living with HIV have been observed to have shorter LTL compared to controls, suggesting that people living with HIV undergo premature cellular aging. In terms of ovarian aging, anti-Müllerian hormone, or AMH, is a protein produced in the granulosa cells of developing ovaries and has a predictable trajectory over a woman's lifespan. It increases in early reproductive life, plateaus in sort of the mid-30s, and then declines until menopause. And we know that AMH levels can be predictive of ovarian reserve. We also know that women living with HIV have been observed to have lower AMH compared to controls. So with this, our three research objectives were first, to compare AMH between women living with HIV and controls. Second, to assess for factors associated with AMH cross-sectionally and longitudinally. And three, to examine for any association between LTL, AMH, and HIV. To do this, we evaluated 462 women, 12 to 50 years of age, enrolled in the CAHR cohort. The CAHR cohort is a cohort study of girls and women living with HIV as well as controls across Canada that are followed longitudinally to assess for cellular aging and HIV-associated comorbidities. For this particular study, we evaluate 256 women living with HIV and 206 controls enrolled between 2008 and 2017 who had one or more study visits at least a year apart. Data collected included demographic, clinical, and substance use data, as well as blood samples for AMH and LTL measurement. For our analysis, we divided our women into two different reproductive age groups, so women less than 35 and women greater than 35. This is because of the predictable trajectory of AMH across a woman's lifespan, where it increases in early reproductive life and then declines thereafter. So we hypothesize that the factors associated with AMH may be different depending on your reproductive life phase. Within these two age groups, we then conducted a cross-sectional analysis looking for factors associated with AMH, and then a longitudinal analysis whereby participants with 2 or more study visits had a delta AMH calculated, so the difference between their AMH between 2 study visits, and then we assessed for factors associated with delta AMH. So this first table here summarizes the demographics of the participants in our study. You'll see that women living with HIV and controls were approximately the same age. The women living with HIV had shorter LTL, lower AMH, were more likely to be of African, Caribbean, or Black ethnicity, to have a lower household income, to be a high school, to have less than a high school education, to be an ever smoker, and to be currently using opiates. This first graph here summarizes the relationship between age and AMH for our participants in the study. On the y-axis is AMH and x-axis is age. Women living with HIV are blue dots and controls are green dots. And you'll see that the trajectory of AMH by age is congruent with what we know about AMH in the general population, whereby younger women tend to gain AMH where it then plateaus, and then older women tend to lose AMH, until menopause. So overall, you can see that in younger women, they tend to gain AMH, and in older women, they tend to lose AMH. So from here on, our analysis are going to be divided into two reproductive life phases, less than 35 and greater than 35. So let's first go through the cross-sectional data. So for women less than 35, we found that age or older age was associated with higher AMH. This makes sense as we know that in younger women, they tend to be gaining AMH. We saw that HIV was associated with lower AMH. We also saw that the absence of any income data was associated with higher AMH. We think that this is a sort of a representation of younger participants, as the girls less than 16 in our study didn't have income data collected. So overall, in women less than 35, we found that age and HIV status were associated with AMH. Next, turning our attention to women greater than 35, here we saw that older age was associated with lower AMH. Again, this makes sense as we know that older women tend to be losing AMH. And we saw that longer LTL was associated with higher AMH, and that current opiate use was associated with lower AMH. So in older women, age, LTL, and opiate use were associated with AMH. Next, our longitudinal data. So as a reminder here, this is for participants who had 2 or more study visits, at least a year apart, where we calculated delta AMH, or the change in AMH between their study visits, and then looked for factors associated with delta AMH. So first for women less than 35, and as a reminder that in this age group overall, these women are gaining AMH, so the slope of AMH is generally positive. So in this age group, we found that HIV was associated with a faster gain of AMH, and that current smoking was associated with a slower gain of AMH. We also saw a significant AMH age interaction term was associated with delta AMH, and I'll explain this further in 2 slides. So overall, in women less than 35, HIV, smoking, and this interaction term were associated with delta AMH. Next, in women greater than 35, in this age group, we only found that their initial AMH was predictive of delta AMH for these women. So this graph here summarizes that AMH age interaction term that I've mentioned. So here on the y-axis, we have delta AMH and initial AMH on the x-axis, and the different colored bars are women of different age groups. So if we focus on participants who had a high initial AMH, so a high initial AMH in a woman in her 20s generally meant that she had a slower gain of AMH overall. Whereas if we looked at an older woman, say a woman who was 35 who had a higher initial AMH, she tended to have a more rapid decline in AMH. And this makes sense if we think about the physiology of AMH in the ovary. In younger years, as AMH increases with follicle recruitment, it eventually reaches a peak where it has a negative inhibitory effect on AMH, and then AMH declines thereafter. So what we hypothesize is that younger women with a higher initial AMH are closer to that peak and have further space, if you will, for their AMH to increase before it reaches its peak. Whereas older women, if they had a higher initial AMH, are more likely to be near their peak, and therefore at maximal AMH sort of negative feedback and inhibition, and therefore to have a more rapid decline in AMH thereafter. So to go through some conclusions, first, we saw that factors associated with AMH are different depending on your reproductive life phase. In younger women, we saw that HIV was associated with lower AMH levels. Though I didn't show this data, we also found that we didn't find any HIV-specific factors that were associated with AMH, suggesting that HIV may be impacting AMH in some other mechanism, which we have yet to identify. In older women, we found that shorter LTL was associated with a lower AMH. And we also saw that an isolated AMH level can be predictive in the change in AMH over time. So what does this mean clinically for the care of our women? Of course, acknowledging that the study didn't have any hard clinical outcomes, but was rather looking at a biochemical marker of ovarian aging. It still suggests that HIV may have some impact on or sort of premature ovarian aging in these women. And I think this highlights the importance in caring for women living with HIV around family planning and the importance of counseling about the possibility of diminished fertility. And then clinicians should also be on the lookout for menopause, earlier menopause, menopause symptoms, and appropriately investigate and treat as necessary. And with that, I'll conclude with some acknowledgements for the CARMA team, of course, all the CARMA participants and all of our funders, and thank you to all of you for your attention.
Thank you, Clara, for that interesting presentation. Again, I urge the audience, if you have any questions, put them in the chat box, or sorry, the Q&A box. But I have a question for you. So I think it was interesting to see that the HIV association was really only significant in the younger women. What do you think that means?
Yeah, so we've spent a fair amount of time thinking about this as well, particularly like why in the younger women HIV and then in the older women the LTL seems to be making a difference. I mean, obviously we can't know for sure. What we hypothesize is maybe that in younger women, when they acquire HIV, there's some form, an initial inflammatory response that causes some sort of a more rapid diminishing of AMH, though acknowledging that, if that were the case, maybe we would anticipate seeing some influence of CD4 count or viral load on AMH, which we didn't see. But certainly in the older women, we do wonder if it's sort of more the cumulative effects of chronic inflammation and aging that then allowed us to see just the LTL making a larger difference on the AMH. And then maybe in the younger women, we see the impact of HIV more clearly because they haven't had that cumulative cellular aging and there is sort of initial inflammatory impact, which diminishes the AMH, but certainly an area that needs to be explored more to understand better.
Was there any ARV differences between your younger women and your older women?
Yeah, so an interesting question, not a piece of data that we included in this particular analysis, but something to be on the lookout for and to be included in future studies.
Okay, and my last question, do you have any perinatally infected women in your cohort? And
yeah,
because that would be super interesting to look at.
Yeah, we did have, I think it was about maybe 20 perinatal. I'd have to look back and see how many, how the exact number, but we did have perinatally infected girls in our study. We didn't see any difference or like association with a perinatal infection and AMH. But again, it was a small number, so we may just not have enough to be able to see the effect of the difference that a perinatal infection might mean on their ovarian aging.
And I hope that those are some of the women that you're following longitudinally, because that would be super interesting to see if their trajectory differs from non-perinatally infected women.
Yeah, absolutely. Yeah.
All right. Well, thank you. Unless there's some other questions from the audience, I will say thank you. Well done.
Thank you.
Very interesting. And we move on to our next presenters. So it's Shaida Alexis Swan presenting with Shelley Tonazzini. I'm sorry if I butchered your name, Shelley. And they are going to present on menopause in women living with and without HIV in 2 studies, Children and Women, Antiretroviral and Markers of Aging, the CARMA study, and the British Columbia CARMA-CHIWOS collaboration.
Well, thank you. Thank you so much for staying with us to the end of the last presentation in this session. Thank you. We appreciate it. We're going to be talking about today menopause in women living with and without HIV in 2 studies, the Children and Women antiretrovirals and markers of aging, the CAHR study, and the British Columbia CAHR-CHIVO's collaboration, the BCC3 study. This is Shada. I'm Shelley, a PhD student, peer research associate, and we're talking today on behalf of the BCC3 study team, CAHR CTN 335. Couple of acknowledgements. First of all, this research has been conducted on the traditional, ancestral, and unceded lands and waters of the Coast Salish peoples, including the Squamish, the Tsleil-Waututh, and the Musqueam peoples. We will be using women to describe people who are sex-assigned female at birth and identify as women, but we acknowledge that not all people who menstruate identify as women, and not all women menstruate, and their experiences may not be captured in our data.
Thank you, Shelley. So for some background, we define early menopause as when a woman's periods have stopped permanently before the age of 45. And previous reports indicate that there's about a 35% prevalence of early menopause among women living with HIV, and that women living with HIV usually go through menopause around the age of 47 to 50, compared to the general population average of 50.5. However, all of our existing data is based on self-report. And in those studies, early menopause has been associated with using intravenous drugs, smoking, having early menarche or starting periods at an earlier age, as well as having hepatitis C. And we care about early menopause because women experience symptoms and consequences of estrogen deficiency. For example, there are vasomotor symptoms like hot flashes and night sweats, as well as vaginal dryness. And then consequences include things like decreased bone density and risk for fractures, as well as impacts on cardiovascular health and many other organ systems. And it also brings up important conversations about family planning, which could potentially be emotionally traumatic if women weren't yet done with childbearing. However, it can be challenging to determine if a woman is truly in menopause, and that's because the World Health Organization defines menopause as no periods or amenorrhea for at least a year, but we know there's many reasons why a woman's periods may have stopped. And that includes things like other hormone abnormalities, structural causes, having an ovarian tumor or undergoing chemotherapy. And commonly in women living with HIV, we see this phenomenon of functional hypothalamic amenorrhea, which is when periods have stopped because of things like extreme stress, having a very low body weight, or using substances like opiates. And in the CAHR study, we see a 21% prevalence of hypothalamic amenorrhea amongst women living with HIV. But luckily, we can distinguish menopause from hypothalamic amenorrhea by looking at follicle-stimulating hormone levels, and I'm going to walk us through why that's the case. So it's because of the hypothalamic pituitary gonadal axis. This is a hormone axis that starts in the brain in an area called the hypothalamus, which releases GnRH, or gonadotropin-releasing hormone. This travels to the pituitary, also in the brain, and then the pituitary releases follicle-stimulating hormone and luteinizing hormone. These then travel via the blood system to the ovary, which then releases estrogen and progesterone. These two hormones then feed back onto the brain to downregulate FSH and GnRH. In the case of menopause, the ovary stops producing high levels of estrogen and progesterone, so we lose that negative feedback, and FSH levels go up. So in menopause, we expect to see high FSH. With hypothalamic amenorrhea, it's the opposite. As the name would suggest, it originates in the hypothalamus, where we'll have low levels of GnRH and hence low levels of FSH, as well as low estrogen and progesterone. So with hypothalamic amenorrhea, we would expect to see low FSH.
So our aims are twofold. One, to compare the self-reported menopause status with biochemical confirmation, the FSH, of menopause status in women living with and without HIV. And two, to compare mean age at menopause in women living with HIV compared to HIV-negative women using self-report and biochemical confirmation of menopause. The hypothesis is that self-reported age at menopause will be lower than biochemically confirmed age at menopause, and this will impact comparisons between women living with and without HIV. So our inclusion criteria included sex-assigned female, age greater than or equal to 35 years of age, and our exclusion criteria was having had the uterus or both ovaries removed and current hormonal contraceptive or menopause hormone therapy. As you can see from the slide, we have not doubled down on the numbers. This is the CAHR and this is the BCC3 study, which is in the process of ongoing enrollment. The target sample size of menopausal women is N equals 84 menopausal women in each group, 90% power to detect a 2-year difference in age at menopause.
So we define menopause status in 2 ways. The first is self-report, asking women on a questionnaire, how would you describe your current menstrual status? And the options being premenopausal, perimenopausal, menopausal, or I don't know. The second way is through biochemical confirmation, where we look at the self-reported age at a woman's last menstrual period and serum FSH levels. And using this, we define menopause as having no periods for at least a year and having a high FSH or being at least 60 years old, or for women who had no periods for a year and were over 55 years old or equal to 55 and had a high body mass index, we also consider them to be in menopause, and that's because of estrogen production by adipose tissue that would impact FSH levels. When we look at participant demographics, participants were very similar with respect to ethnicity, substance use history, age at menarche, and body mass index, and the majority of women living with HIV had an undetectable viral load. Women living with HIV were slightly younger, but when we look at, there are more significant differences with other variables. So women living with HIV were more likely to have a low income as well as less than a high school education. They also had more live births, as well as were more likely to have current or past hepatitis C. When we look at self-report versus biochemical confirmation of reproductive phase, for women living with HIV, 69 reported that they were in menopause, whereas this was confirmed by FSH levels in only 57 women. When we look at controls, the numbers seem to be more concordant, with 68 saying they were in menopause and 65 women having FSH levels consistent with menopause. When we look at overall concordance between self-report and biochemically confirmed reproductive phase, we see concordance in 86% of women living with HIV, but much higher in 95% of the HIV-negative women. So overall, it looks like concordance between self-report and biochemically confirmed reproductive phase was higher amongst controls than women living with HIV. When we look at age at menopause, first only defining menopause by self-report, we see something very similar to what others have observed, and that's that women living with HIV went through menopause about 2 years earlier than HIV-negative women, around the age of 48. Again, this is very consistent with past reports. However, when we only define menopause based on biochemical confirmation, we no longer see any difference, and it looks like women living with HIV and controls both went through menopause around the age of 50, which would not be considered early menopause.
So in conclusion, the limitations obviously that we're currently underpowered, and also the self-report data for age at the last menstrual cycle. Preliminary signals of little difference in menopause age between women living with or without HIV. Also, distinguishing menopause from amenorrhea can impact treatment approaches. And also FSH measurements could have a role in research for determining menopause age. And also, maybe most importantly, and in my experience of talking to the women about their experiences of menopause, is the importance of discussing the phases of menopause with women and really bringing the education level up between care providers and in clinic, as well as all sorts of other outreach opportunities that we can come up with. I think that's it. The next slide. And yes, finally, just a big thank you to all the CARMA and BCC3 participants for contributing to this research. We'd like to acknowledge the BCC3 and CARMA teams, our co-investigators, and our community supports, as well as our funders. Thank you so much for staying for the length of this presentation. We hope we can answer some of your questions.
Thank you.
Thank you, Alexis and Shelley. That was an excellent presentation. So I encourage questions again from the audience, but I have a couple of questions. As a woman hoping to reach menopause soon, because I'm tired of being in that perimenopausal period. Now, tell me a little bit, excuse me, tell me a little bit about are the women living with HIV sort of this discordance between whether they are menopausal and they think they are menopausal, so they are not getting their periods, I presume?
Yes, so they're self-reporting that they haven't had a period for a year, and then that's being assumed to be menopause. Yes.
Okay, so why do you think they're not getting their periods?
Yeah, I think often, I mean, for some people it is menopause, but I think that because we see such a high prevalence of hypothalamic amenorrhea, and especially because of things like having a low body weight or having substance use, like opiates specifically, can suppress GnRH release, and that would then prevent periods. Or even things like just having an extremely stressful life, those can all stop a woman's period for at least a year. And there's even good data from the Women's Health Interagency study where they followed women living with HIV who had amenorrhea for at least a year and followed them to see if their periods came back. And I believe in 38% of women, their periods came back eventually. So they weren't menopausal. Their periods had just stopped for some other reason.
I hope we're not getting any surprise end of life babies from these women.
Yeah.
We have a question from the audience. Do you reckon these findings will change once you have a much larger sample size?
So when we look at our power, we're at about 80% power right now to detect a 2-year difference in age at menopause. So I would say that we're pretty close to being powered to really see a difference. So I don't expect it to change too much, but of course we will we'll do those final analysis when we have the final cohort, which we're quite close to. So I think that'll be coming in the next few months.
Now, and I'm sorry if I missed this, but was there any associations with what kind of antiretroviral these women were, whether there was discordance in their reports?
We haven't looked at type of antiretroviral, and I've done just some preliminary multivariate modeling on this. So of course that might change once we have the full cohort, but so far it looks like the only factor that's associated with earlier menopause is smoking, which is not surprising. That's also seen in others, but HIV does not seem to be associated with age at menopause, consistent with what we're seeing with these univariate analyses.
And I think too, just to add on to the previous question, the education piece around women not knowing their menopausal status and the differences in between and what can impact menopause, and also that hormone therapy treatments are available to women both living with HIV and not, and that is still more research to come, more research necessary, but certainly more education and more discussion around menopause in general between women living with HIV or not.
Absolutely.
Is there any psychological effects that these women have told you about, having this discordance or thinking they're in early menopause, or?
I think some women speak to, I can't remember my last period. It's well over a year ago, when in fact it was only 5 months ago. Or, I haven't had my period but I had a little bit of spotting. Or there's not a clear understanding of when's I don't know. People don't necessarily put their period in their calendar anymore. We don't carry daytimers the same way. But I think that there's that information gap that women have in their own brain, like, can't remember. And it's similar to, I guess, even trying to think of, when was my last period? Am I pregnant? It's kind of like different but similar.
Yeah, I would agree with that. And I would say that it speaks to the clinical importance of talking to women about their periods and about like what menopause is, how to look for the signs, how to know if it's normal that your period has stopped or something else might be going on here.
Yeah, well, I'm all for promoting more talking about all of these kind of things, menopause, menstruation, all that kind of stuff. We should talk about it more.
Really?
So thank you very much. Excellent presentation. Thank you to all our presenters. I really enjoyed this session, and I'm sure our audience did too. And we're well within time, so that's great. And I hope to see you all in the clinical science keynote coming up next. And thank you to my co-chair, Mike Silverman, and the tech support of our conference organizers. Thank you.